Good morning, everyone. I see students are still joining. Let's give it another minute or so. Can you please turn on your videos? I can see you all. Good morning, Andrew. Okay, great. Okay, let me put this on recording.
Recording in progress.
Good morning, Ellen. All right. So this is getting recorded. Let's get started. I know we had started with the questions, thyroid questions yesterday. So anyone from DO class who would like to answer this question? Take a minute to read. Yes, Christian, please go ahead.
I think the answer would be decreased TSH because it's describing like hyperthyroidism.
Yes. How did you get there, Christian? Can you tell us?
So I figured out that it was hyperthyroidism because it would like increase her metabolism. So I was thinking, okay, she's hot a lot, she's kind of jittery, and then the big thing that gave it away was that her temperature was like 37.5 degrees Celsius, and then her pulse was 101. Her respiratory rate was elevated. She has elevated blood pressure, so everything's like increased.
Very nice. Thank you so much, Christian. So just to reiterate what Christian just mentioned, the patient shows all the symptoms for hyperthyroidism, right? So she's very anxious. She is going around like, spilling her coffee, nervous. And then she has lost some weight. So that shows us that it's high BMR, right? Then temperature is high, pulse is high, cardiac output is high. So all symptoms for hyperthyroidism. And that would bring the TSH down. Why, Christian? Can you explain us, please?
To be honest, I don't know. I just memorized that hyperthyroidism is decreased TSH.
Okay,
I
no
can
worries.
try.
Thank you. Yes, please, Michael, do you want to go?
Yeah, I was gonna say you have the figure on the slide, but long story short, the thyroid produces thyroid hormones that act via negative feedback inhibition on the anterior pituitary to inhibit its secretion of TSH, right?
Beautiful. Yes. So just reiterate few things. Yes, Dhruv, you are absolutely right. So these are the negative feedback. So there are target endocrine tissues in your body, right? Thyroid is one of those. Dr. Shah must have. Usman, I'm going to post them today because I didn't finish the questions that day, so I thought let me finish as many practice questions as we can do today. So after that, yeah. So after this session, I'll post it. Um, so basically, you have hypothalamus, which is your master of this endocrine orchestra. It is releasing certain hormones, right, which are releasing factors. We call them releasing factors. They are going and tapping the pituitary, anterior pituitary basically, to get those trophic hormones from here. So stimulating, or it could be CRH, it could be, you know, growth hormone, right? So all those, they are coming and they are tapping the target tissues to get you the actual hormones which will be working on different tissues, right? So TSH is one of those which is going and talking to thyroid gland to get more thyroid hormone out of it, which is T4 and T3. T3 basically the active hormone that works on your tissues. We're going to talk about it in a second. Just I'm going to the second slide, but we saw that this is a case of hyperthyroidism, right? Where the thyroid gland is producing like tons of thyroid hormones, and they are giving a negative feedback basically to the pituitary to slow down on the TSH, right? So TSH is low. What do you think is happening in Graves' disease, which is giving rise to these excessive thyroid hormones? So you just told me that the TSH levels are low, right? So what is happening in Graves' disease, which is hyperthyroidism example? Yes, Messia?
So for Graves' disease, they have autoantibodies attack or immune system is attacking their thyroid, which is causing a false production, so an overproduction of the thyroid hormones. So
Yeah.
they're yeah.
Yes. Absolutely. So is your TSH working on the thyroid gland or the follicular cells, right? Which is producing you T3, T4, as you can see in the picture here, right? You need iodine for this whole process, right? Which will be binding to the thyroglobulins, which has a tyrosine moiety here. And that's how your monoiodotyrosine or diiodotyrosine, they are being made, which are joining further. So two DITs joining to make T4, one DIT and one MIT joining to make T3. And this whole thing will be endocytosed because this is a pretty big thing now to just get diffuse into the cell, right? So you want to endocytose this. And that's where the rest of the things will be recycled back in the cell to make more T3, T4. But here the hormones are being poured out into the circulation, right? And then I'm going to talk about like T4 and T3, they'll be circulating in blood, but they're not doing anything until unless they get the target tissues, and we'll talk about that in a second. So instead of TSH starting this whole stuff, so wherever you see this red mark, that means your TSH was actually helping all these processes that are happening here for the formation of T3, T4. Now, we just said in Graves' disease, as Messia just mentioned, those are thyroid stimulating immunoglobulins. I put it up here for you guys. So thyroid stimulating, these are TSIs, they just talk to the TSH receptors. Instead of TSH going and talking to the cell, this has become redundant now. These IgGs, they are actually going and talking to the receptors, and they're starting the whole process of making T3, T4. So poor patient, it's an immune issue. Yes, Thomas, yes, you're absolutely correct. Yes, they have the affinity for those receptors, basically. So in the end, you have TSH levels low, but still patient is having hyperthyroidism. Okay, any scenario where patient is having hyperthyroidism and TSH levels are high? Can you think of any scenario? TSH levels are high and patient is having hyperthyroidism. Beautiful, Jay. Yes, absolutely. Pituitary adenoma, where TSH is being poured out, right? And poor patient, the thyroid gland is under the tapping of that TSH. It's a stimulating, right? So they will come and tap that particular target gland to get more thyroid hormone out. All right, wonderful. So I have put for you guys three things up here: thyroglobulins, thyroxine binding globulins, and TSIs. Can you give me differentiation between these three? So Brianna is asking, does that mean there is no negative? Yeah. So Brianna, unfortunately, whenever there is tumor sitting, which is constantly spitting out TSH, unfortunately, the feedback control is gonna just, will be out of control because you don't have control over a tumor, right? Yeah. So can anyone differentiate thyroglobulins, thyroxine binding globulins, and thyroid stimulating immunoglobulins? Yes, Erin, please go for it. Thank you.
So thyroglobulins bind like MIT, DIT, and the thyroid hormones in the lumen of the follicle, like
Yes.
in the colloid.
Yeah.
And then the thyroxine binding globulins bind the thyroid hormone into the circulation. And
Beautiful.
thyroid stimulating immunoglobulins are the immunoglobulins that attach to the TSH receptor and stimulate it.
Very nice. I just brought all these three things up. I may have some things in my notes as well, in speaker notes, so please make sure you read those. Thyroglobulin is the moiety that you need here to make the thyroid hormone, right? And your T4, T3 in circulation, they don't go, like they're not in a free this thing. Somebody has asked for meeting summary here.
Sorry, I'm just experimenting with the AI options.
Okay, I'm not sure how it works. So can we, today, can we leave it for today?
Yeah, that's okay. I'm sorry.
It's okay. I just, want to experiment first myself and then we can go from there. I don't want anyone to get any wrong information like out of the whole meeting, right? And this will be recorded, Diego, so you'll get it. All right, so where were we? So your T4, T3, they are not all by themselves. They're not free in the circulation. Rather, they are binding with thyroxine binding globulins, and then they are getting to the target tissues, and that's where they'll have their function. And TSIs, as we mentioned earlier, these are immunoglobulins, which are actually acting as TSH and talking to the TSH receptors to make more T3, T4 in the, hyperthyroidism. Here, so if you look at the thyroid hormone, this is the only hormone which is not a steroid hormone, but acts like one. So it gets inside the cell, and then T4 gets converted into T3, which is the active form, 5' iodinase, which is going to convert to T3, which is going and talking to the DNA itself. So there is a thyroid regulatory element where it goes and binds, and that's how it brings actually the transcription of different proteins, as you can see. So it takes a major role, it plays a major role in growth, even bone maturation of CNS. This is basically, I will go to the next slide and I'll explain you how important role CNS plays, thyroid plays in maturation of CNS during pregnancy. And if pregnant mothers, they don't have enough thyroid or the thyroid element is low, that can impact the baby's development. For the growth, you'll see a stunted growth, the bones are not maturing properly, and plus there will be intellectual disabilities if thyroid or thyroid hormones are not present in normal state, right? BMR, it plays an important role in BMR. Why? Because it actually stimulates sodium potassium ATPase activity. So Brianna is asking 5' iodinase or deiodinase. Yeah, it's the same thing. It's the same thing, Brianna. It basically has to work with taking out one iodine out of the rings from the T4 and then convert it into T3 basically. Okay. So it increases oxygen consumption, heat production, and BMR overall. So metabolic rate is high under hyperthyroidism, what we saw in the previous case. It also helps for the glucose absorption. So you may see hypothyroid patients, they are having trouble absorbing glucose. So they'll be always having, sweet tooth, trying to get more sweets, right? Otherwise, like if you see, it's very lipolytic effect or catabolic effect that thyroid may have. Cardiovascular side, it will increase the cardiac output. It has very much catecholaminergic actions because it increases the beta adrenergic receptors as well. Yeah, we'll go there, Diego. Just wait. I want to discuss the cretinism first, and then we can talk about it. So there are certain proteins, as we mentioned earlier, thyroid hormone directly controls synthesis of those new proteins, be it sodium potassium ATPase, calcium ATPase, all the proteolytic enzymes, or lysosomal enzymes even. So all of those, they are under the control of thyroid. So let's do few more questions, and then I will describe, Diego, that one. So anyone who's ready with this question, let me know. As I mentioned you earlier, I'm not going to give you any negative question in the exam, but this is just for the, learning purpose that we have it here. Anything that
I could try.
Yes, please go ahead, Zainab.
I think it's C because for C it says normal T4 production, but Graves increases T4.
Very nice. So there is no normal T4 because in Graves, TSIs, they are going and tapping the thyroid gland to get more T4, T3, right? So there will be high circulating levels of T3. There are high TSIs. There will be high RT3 levels as well. So that is inactive form of T3, basically. So when T4 gets converted into T3, either it's making T3 or RT3. So RT3 is basically inactive form, nothing like something that you may not know. So just follow the book and you will see it's just how the iodine is being plucked out of the T4 hormone.
I have a quick question about that.
Yes, Zanab.
So with Graves' disease, does it have to be free T4 or could it be like you have TBG and TBG is increasing T4, so it's bound?
So basically, it's increased T4. When thyroid gland is making T4, 95% of that hormone which is coming out of the follicular cells is T4. And then it is getting converted into T3, right? So yeah, there will be high T4 production.
Okay.
Yeah. All right, Dhruv, thank you. Yes, Amir, that's correct. So just keep in mind, you're going to see, as I mentioned earlier, you're going to see all pathophysiology questions for thyroid, for adrenal, multiple things that can happen by increased or decreased thyroid hormone, right? So just be ready with it. What is goiter? Anyone? And do you think in Graves' disease there could be goiter? That is enlarged thyroid gland. Very nice. So what are the different causes for enlarged thyroid or swelling of neck? Low iodine. Very nice. Enlarged, yes, low iodine. Beautiful. Iodine deficiency, some of the countries, like underdeveloped countries, you will see goiter, like a common problem there because they'll have iodine deficiency, low T4, very nice. Thyroid becomes hypertrophic. Yes, Tom, very nice. Lack of thyroid, yeah, beautiful. So do you think in Graves' disease one can get goiter? Graves' disease? Yes, yes. So at any point of time, if TSH is coming and tapping the thyroid gland, asking for more T4, T3. It can be in Hashimoto as well, which is autoimmune, right? Where immune cells, they are going and attacking the thyroid gland. So thyroid follicular cells are not there to give you enough T4, T3, right? TSH numbers are going high and they're constantly tapping the thyroid gland. So it's trying to, bring the hyperplasia of the thyroid gland. So yeah, very nice. All right, great. Thank you. So now we come to the cretinism. Can anyone describe what cretinism is?
Can I try, Dr. Kaur?
Yes, Alicia, please go ahead.
Okay. Is it intellectual disability and stunted growth due to a lack of T4 when mothers are iodine deficient?
Beautiful. So basically, during the pregnancy time, I put gestational week 13 here intentionally. So you are all aware that by week 13, the thyroid gland in the fetus is already kind of developed. And by week 16 to 20, fetus has its own have their own thyroid production going, but still maternal thyroid hormone has to be there in enough quantity to take care of the pregnancy fetal growth. So in case thyroid is going low, the thyroid hormones going low, it may impact the development of the baby, right? So they'll have stunted growth, intellectual disabilities, bones are not properly growing, or growth is not proper in that baby, right? How we had discussed earlier. Now, Diego had that question for intellectual disability. So thyroid hormone, there is still research going on this. Thyroid hormone plays a big role in synaptogenesis or synapse to synapse docking when it's happening. So not only during gestational period, but in adults, if thyroid hormone is going low, it can cause dementia. Actually, if you know, people who are aging, they are coming with dementia in physician's office, they will be always asked to get their thyroid hormones checked because that could be one cause that these patients may have, apart from getting dementia from Alzheimer's or several other reasons or vitamin deficiencies and stuff. Yes, Diego.
There is a question about the TSH level in Graves, that it should be low. I'm not sure. Could you clarify that?
Oh, yeah, Jay. Oh, Jay has a question. Yes, I'm sorry, I didn't see that. Yeah, TSH levels are low in Graves' disease. What is it about, Jay? I didn't get you. Can you please explain? That's what we were discussing, right? That was this question was about. Because TSIs are high, right? Here, this is what we discussed in this question. Diego, is there any issue?
I think
Yes.
he's confused about why it causes goiter because you would think that increased TSH causes goiter, but here we have decreased. But I think it's just because it mimics it and the thyroid
Yeah,
still
the
thinks it's high.
TSIs are mimicking. Yes, Jay. Yes, TSIs are mimicking, and that's why they can have goiter.
But what about the pituitary production of TSH itself, right? It's not being like it would have continued to produce it as normal instead of
In
decreasing.
Graves,
Yes.
yeah, Graves, it will be low, right? Because that is still under feedback. Your pituitary is fine, right? So in case someone is having Graves, the TSIs, they are going and talking to the thyroid gland, right? And that's what is giving excessive T4, T3, which is giving a feedback to the pituitary. So you're gonna have low TSH levels here, but still have thyroid gland enlargement by those TSIs, which are going and prodding the thyroid gland. Make sense, Diego?
Yeah.
Okay, and how about Jay? Jay, you got it? Okay. All right, is everyone clear? All right. Okay, so let's get going. Where were we? Thyroid stimulating, yes. So cretinism, I'm going back here, Diego. It's not only the synaptogenesis, synapse to synapse talking, I mean the transmission from one synapse to the other, right? And then also in myelination, thyroid has been implicated into that. So that is leading to the intellectual disabilities during the gestational period, or the baby will be malformed when they are born with low thyroid during pregnancy for because now the thyroid hormone check is a must thing for the pregnant mother's early pregnancy. Okay, not only the gestational diabetes and stuff that they want to check, but also the thyroid hormones are must thing. Okay, oops, I'm sorry. Go ahead. Anyone who's ready? We already kind of discussed, so if you are ready, let me know.
I can try.
Yes, please, Zanab, go ahead.
I think it's D.
Yeah, D is the right answer, right? If circulating levels of iodine are low, it's going to impact your thyroid hormone production, right? If thyroid hormone is not enough, then it's going to impact the TSH levels, right? TSH levels are high, they're going to cause the enlargement of thyroid gland to get you more thyroid hormone out of it. Make sense to everyone? Are you with me on this? Yes? Okay. All right. Let's move forward. Yeah, so anything that you will see read on the slides, you've got to finish it for the exam, please. And as I said, you will see questions on every thyroid pathophysiology or every adrenal pathophysiology. Thomas is asking, what if the goiter is caused by something else like autoimmune disease? Yes, yeah, we talked about Hashimoto's, right? So autoimmune problems are the common cause for thyroid problems. So hypothyroidism, when immune cells, they're going attacking the thyroid gland follicular cells are less there to produce the thyroid hormone, right? Or iodine, we just discussed. So anything which is not letting the patient make enough thyroid hormone is going to bring more TSH, and TSH is going to cause the hyperplasia of the gland. Is that clear, Thomas? Oh, you are asking, will iodine levels still be normal or reduced? Well, it depends how much iodine you have introduced into your diet. People who are hypothyroid, they are always suggested that they should, they should have iodized salt, which is readily available these days, or iodine supplements. They can help them to, at least help their thyroid hormone production a little bit. Thomas, is it helping? Yeah. So one more question. If someone is having hyperthyroidism, as was the case that we were discussing earlier, they are showing such big cardiac output, right? Their blood pressure is high. How do you think you will treat your patients? Sorry, for hypothyroidism, you can just introduce every day one pill of certain dosage that they have to have in the morning, and then they should resume their functions fine, right? If someone who's having, Jay's telling us beta blockers, that is correct for the cardio issues. Since thyroid has catecholaminergic activity, it stimulates beta receptors more, right? So you want to calm them down because you want to give them some relief from all the cardio symptoms that you are seeing here, right? Or the catecholaminergic activity that you are seeing here. You want to give them quick relief. So you want to introduce the beta blockers there. Overall, what will you give your patient? Yeah, Maram. Yes, Maram. Thank you so much. PTU for the long term. What is PTU? Yeah, Diego, somatostatin is always the thing, but here you want to give them something more specific, which will help them long-term relief. Yeah, that's thyroid peroxidase inhibitor, right? All these reactions, if you see, they are helped by the thyroid peroxidase, right? So if you introduce PTU, that's an inhibitor for this thyroid peroxidase, which is gonna block these reactions, and that's why you can calm down T4, T3 production in these patients long term, right? So you want to put your patient on propyl thiouracil, right? PTU. Okay. And for the cardio symptoms, you want to introduce the beta blockers in there. Wonderful. Very nice. Just keep an eye on the drug list. It's already sitting for your exam, exam help on Canvas, how we have for every exam. So just make sure you go over those. Okay. All right, let's get going. Oops, I'm sorry. I don't know why I'm doing this. All right. Anyone who's ready, let me know. Which layer of adrenal cortex produces most of glucocorticoids? Yes, C is the right answer. What does zona glomerulosa do for you? It makes what? Melanocorticoids. Very nice. Reticularis is for androgens. Very nice. And medulla makes you? Yeah. Yes. Catecholamines. Yes, beautiful. Okay, I think we're doing well. I'm just going to go over the biosynthetic pathway one more time. Yes, yes, Fiona. Yeah, good. I already put it up here. You can see here is salt. We have put salt here. So melanocorticoids, they'll reabsorb your salt, right? Cortisol is for sweet, gluconeogenesis, right? And sex is for the androgens right here. Okay, great. So everyone is knowing this GFR, that is glomerulosa, F is for fasciculata, and R is for reticularis, right? So cholesterol being the precursor that will start your whole pathway. Here are the key enzymes that you may want to keep an eye on. Any mutation on these enzymes will block the pathways, right? And it would shunt to make to the other side, make other products here, right? Another thing that you also want to keep in mind, the cholesterol desmolase. This is the enzyme that would need ACTH help. That would stimulate the whole, this is the rate limiting enzyme here, right? So that's going to start the whole thing. So in any scenario, if you block this enzyme, if you block cholesterol desmolase, what do you think you can help? Which disorder or disease? Yeah, these are all adrenal cortex. Yes, Cushing's would be helped, right? This is a rate limiting enzyme. So ketoconazole, we call it ketoconazole, that drug that will inhibit desmolase, right? Or you can use metyrapone, which is 11 beta hydroxylase inhibitor. That is also for Cushing's. You can use it. Okay. Book has all those drugs named, so make sure you go over them. All right, next question. What are TSIs? I'm just repeating it again and again, so you are ready for the exam. Beautiful. Those are the cause for the Graves' disease. What is thyroxine binding protein? Thyroxine binding protein. Yeah, it's a carrier protein for T3, T4. Beautiful, Alicia. Thank you. Protein that binds to thyroid hormones in the blood. So circulating hormones, they are not going free in your circulation or in your blood. They will be bound to some protein that is called thyroxine binding. A hormone that is released from pituitary that stimulates thyroid hormone release. What is that? B is what? TSH. Beautiful. Cause of Addison's disease. Anyone? Adrenal insufficiency. Yes, very nice. But the cause is what? Yeah, autoimmune antibodies. Yeah, these are the immune cells which are going and attacking the adrenal cortex. So yeah, beautiful. Yes, there will be loss of negative feedback, Presume. You are absolutely correct. that will give the patient more ACTH levels, right? Okay, I think we are doing good. So I just want to repeat it again and again so you guys are just ready. Yeah. Okay, this is for you to prepare by yourself. Just do those. T3, T4 is it's a amine hormone. It's not a protein. Thyroxine, right? Yeah. Okay, next question. By the way, you got to keep an eye on which are the peptide hormones, which are steroid hormones, you know, and the amines as well. B is the right answer. Very nice, because BMR is going down, so patient will be feeling very lazy, fatigued. They'll have low BMR, low oxygen consumption, lower heart rate. And what do you mean by A? Anyone? Exophthalmos? What is it? It's protruding, bulging eyelids, right? It's in Graves. Very nice. There is inflammation in the retro orbit, right? Which is causing the swelling or edema behind the eyes, and that is bulging or protruding eyes. Yes, yeah, correct. I mean, yeah, for fun, Diego, it's fine, but you know, patients who have it, it's really sad to see them. Okay, all right. Why do you think, now that you have done a session with Dr. Shah as well, why do you think that the hypothyroid patients will have menstrual cycle irregularities? 100 marks for the student who will explain this. Anyone? Yes, Zainab. Beautiful. Would you like to explain it?
I think it's because when the menstrual cycle becomes irregular, the low thyroid hormones they lead to increased TRH, and then TRH would then stimulate prolactin, and then prolactin would then suppress GnRH, which would then reduce FSH and LH, and that would give you irregular menstrual cycles.
Beautiful, beautiful. 100 for you. Yes. So see, prolactin is talking directly to hypothalamus. Always keep in mind, we'll talk about it more in reproduction portion. So prolactin inhibits GnRH, and GnRH is the releasing factor for LHFSH from the pituitary. If you don't have LHFSH, ovulation can't take place, right? Or the cycles won't be normal, and there will be menstrual cycle irregularities because TRH is going high. Patient is trying to get more TSH there, right? And in order to do that, there is high TRH levels from hypothalamus, and that is actually interfering the prolactin rise that is there because of more. And remember, dopamine has a negative effect. So dopamine neurons, they are directly actually going and talking to the lectotrophs in pituitary, right? So they'll have a direct negative control of prolactin secretion. But TRH has a stimulatory action on prolactin. So if prolactin is high, it's going to interfere with the ovulatory cycles. And that's why a patient will have menstrual cycle irregularities if they are hypothyroid. Okay. All right. Wonderful. So all these things that thyroid is working on, you can think about certain questions that way. Yeah. So Alan is asking, how does TRH impact? So TRH has a stimulatory effect. So if you go back to the last session, it stimulates prolactin release. If you go back to the last session where Dr. Shah must have talked about the prolactinoma and all that stuff, I believe he did. I don't know. If he didn't, he probably talk in the supplemental today. You are meeting with him at 12. But anyhow, if you're still not clear, I'm gonna bring it back in my reproduction session again, or just come see me. We can talk about it more. Okay, all right. So this is for you to prepare. I've kept some empty slides there. All right. Question for you. Which of the following homeostatic imbalances usually result from deficits in both glucocorticoids and melanocorticoids? Very nice. Addison's is the answer. That is the correct answer. Why do you think that the bronzing is happening in Addison's? Of course, patient is deficit in glucocorticoids, and so you want to treat them with both. Yeah, that is increased ACTH, which has a fragment of MSH sitting on it. So since there is a loss of negative feedback, no cortisol being produced from adrenal cortex in such patients because of the immune attack on the adrenal cortex, right? So patient is having high ACTH levels. Now the MSH activity would overstimulate the melanocytes, and patient will have pigmentation or the bronzing of the color that you will see. What is happening in cretinism? I'm just repeating again and again so you guys are ready for the exam. Cretinism is no, it's not hyperthyroidism. Zainab. No TSH. No, 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 no. It's hypothyroidism, right? Cretinism is what? It's a stunted growth in the children, right? In the newborns. So basically, lack of thyroid hormone during pregnancy can lead to congenital hypo. Yes, yes, absolutely correct. So you want to supplement your patient with the thyroid hormone when they are born in order to, help them out a little bit. But during pregnancy, one has to make sure that there is enough thyroid hormone in the mothers, which is taking care of the mental growth and mental well-being in the patient and the bone growth and the growth as such in patient. It's not as reversible, Abram, unfortunately. It's not as reversible. You got to take care of it during pregnancy, during the gestational time. You can help the patient a little bit, but the myelination or the synaptogenesis that has been impacted during the gestational period, unfortunately, that can bring the intellectual disabilities in the patient. Yeah. You just give them thyroid hormone, Diego. T3, there are thyroid hormone pills which are available that you have to take daily to supplement in case, I do take thyroid every day. I have to take it because I had Hashimoto's. So I have to supplement it every day, every morning, before any meals. So it gets absorbed in the body and get me going throughout the day. Yeah. So they determine the levels, the blood levels are determined, and how much you are low, that is determined according to your weight. And then I'm given how much I need daily basis. So I get it checked like every 3-4 months. Yeah, that's how you supplement it. All right, here we are. Cushing's, everyone knows Cushing's. We're good on that. Cushing's disease and syndrome. Can anyone clarify quickly? High cortisol, beautiful. You need to know all cortisol actions: gluconeogenesis, catecholinergic activity, osteoporosis, the sleep cycle is disrupted, right? in hypercortisolism because this is your wake-up hormone. Cushing's have low renin. Good question. Cushing's, not really, because cortisol is the one which is going to give negative feedback, Messiah, right? So ACTH levels, they're not going to be high in these patients, right? So
I was wondering because of the aldosterone part with angiotensin.
yeah, it may, yeah, not really. I don't think it would be, even though cortisol does have mineralocorticoid action, that may bring, um, I have to look into this.
Okay.
I
Yeah, because
haven't
I was
looked like
remembering
full
the
data.
rest.
It is possible. It is
Oh,
possible that, the cortisol is already taking care of all the melanocorticoid activity that aldosterone has to perform. And you are absolutely correct. Your aldosterone regulation is through, volume contraction and
mhm.
stuff. So RAS system. It may have
Okay.
overall, if we look at it. Um, yeah, it is possible. Yes. Okay. All right. I think we're doing pretty well. So next question. 17 alpha. You have to be ready with all CAH. Did biochemistry finish yesterday, CAH?
Yeah.
Yes.
Yeah.
I think now that we are running it together, it should make more sense. Okay, 17 alpha. A is not correct. Who's telling me A? A is not correct. Anyone who would explain it?
I mean, I thought it was A because, I mean, there is hypertension, but I thought virilization would be absent because if you have a deficiency, then you would have less androgens.
You
So
are
we would have.
correct. I was just kidding.
Oh, okay.
A is the right answer. No, I was just kidding. I was just trying to. Yes, that's the correct answer. You will see hypertension because everything is shunted towards one pathway, right? And there are no androgens there, so virilization will be absent. Now, what is B? Quickly. Hypertension absent, virilization present. 21 beta, very nice. So Diego, first one is 17 alpha, right? B is 21 beta, very nice. C is what? C is what? Normal, very nice. Yes, Maram, you are correct. You and I, everybody, right? No one wants to have hypertension, and the virilization is absent as well. Very nice. Okay, wonderful. D is 11 beta. All right. So have confidence in you. You were correct in saying A. I'm sorry. I just wanted to trick you guys and see where you are. Yes, but that's correct. Let's go over one more time. And we talked about it, why 17 alpha will have low aldosterone levels, right? Someone was showing me a map from biochemistry where they were showing high aldosterone levels, which is not correct in this scenario because whenever a mutation happens, the other pathway will be in abundance, right? You will have 11 doc, which is taking care of aldosterone function already, all the melanocorticoid activity here. So your the contraction or the volume contraction is not taking place at all. So the RAS system would be inhibited. So you won't have, remember, I told you yesterday, for final aldosterone. Yeah, Dhruv, that's right. Only few patients may see it, But ideally, if it's not a matter of long-term cure. I don't know why she said that, but thing is that if it's a mutation, it has to be happening from the very beginning, right? So if it's a mutation, it's gonna shunt the whole pathway towards this side. And if you have tons of 11 dark, you're gonna see expression of aldosterone and renin. Remember, you need angiotensin II to stimulate aldosterone synthase. And if you don't have RAS system activated, you don't have angiotensin II. You get my point? So that's the only way to get you make aldosterone, right? So just keep that in mind. We may be bringing you some into second year when we do multidisciplinary board reviews. We bring these cases, and sometimes we are giving the renin levels and all that stuff when we present these cases to you. Yeah, Dhruva, I'm not sure, but I have seen when I was reading online, I've seen some data where they'll show some normal aldosterone levels. So maybe she's correct. I don't know. They may know it better because ideally this is a biochemistry case. So Swan is asking, can't you have high glucose levels because of high court? Yeah, partly, but again, if your 11 doc, which is mainly mineralocorticoid activity, it's taking care of the whole system. You may not be making as much of corticosterone, right? You're going to the next step towards making aldosterone. But yeah, it is possible that they are having high, because of the gluconeogenesis activity of this corticosterone, which is a glucocorticoid basically. Yes, everyone clear about the whole thing? So what causes hypertension? Yeah, high doc. Yes. Yes, Aaron, you're correct. Because I told you whenever a mutation is happening, the other pathway will be in abundance. All the metabolites that you see here, they're gonna be in abundance, right? Because we have this whole thing shunted towards this side. Sorry, shunted towards this side because this is blocked, right? Is it clear, Aaron? Yeah. So why
I
do
just
we?
have one quick follow-up question.
Yeah,
Why
sure.
is the RAS system inhibited?
So your RAS system, when does it get activated? You tell me.
Low blood pressure?
Low blood pressure, right? So if your 11 doc already took care of your sodium reabsorption, that is your mineralocorticoid activity, right? If it has already took care of this, then your RAS system, your renin levels won't go high because they are not seeing the blood pressure dropping.
I see. Okay, thank you.
You're welcome. Abram, you have question? Yes.
Yeah, I want to ask a question about the prior slide. So for 17 alpha deficiency, would they be hypokalemic and alkalotic
In 17 alpha?
deficiency? Yes.
Yeah, they may see because they are basically throwing the potassium out, the potassium secretion. Yes, that would happen.
And with that, like potassium sparing, like those spare lactones from last.
Yeah, you want to. Yes, yes. Okay, 21 beta, why do they see hypotension and hyperkalemia? Yes, Andrew, please go ahead.
Oh, thank you. Yes. So for hyperkalemia, it would be because we don't have 11-doc nor aldosterone. No potassium's getting shunted out and no sodium's coming in. So basically, potassium goes up, and then natremia, sodium goes down, and that leads to hypertension.
Yeah, beautiful. So you have high androgens, the whole pathway is shunted towards high androgens, right? So high androgens, they are causing the masculinization, right? Especially the female patients, as we discussed yesterday. The males are not affected as much because this androgens that we are making here from adrenal cortex is just the peanuts, right? As opposed to what testes are making, right? So females female fetus would be impacted the more. They'll have ambiguous genitalia. So if you see my clinical stem in the exam, which is showing you ambiguous genitalia, just wait until we finish the whole reproduction. There may be some more cases coming like that where we will be talking about DHT and other stuff. So we can wait until then, but 21 beta, 11 beta, high androgens, they can cause ambiguous genitalia, but your clinical stem is showing you low blood pressure, high potassium levels, you know what kind of deficiency it is. Okay, so be prepared according to a clinical stem. And I would suggest start doing all the pre-test questions and your Q-bank questions already. Start working on them and let me know if you have any problem. I can help you out. All right. Yes. Yeah, hypokalemia because no sodium reabsorption and no potassium secretion. Yeah. Yes, Joy, you have a question?
Hi.
Okay.
Yeah. So I think I'm still a little confused how you would tell 21 beta hydroxylase deficiency apart from 11B
Yeah,
deficiency.
so for 11B would be hypertension, right? Why? So if you look into the picture here, if 11 beta deficiency means you will get a block here. You are still able to make 11 dark.
Okay.
You see my
Okay, I
point?
see.
I think
Yeah.
I had, yeah, here it is. So the block is here, right? So 11 doc is being mineralocorticoid. It's going to take care of all the aldosterone functions and it's in abundance now. So it will cause to make patient hypertensive and hypokalemic.
Okay, I see. Thank you.
Makes sense? Yeah, is everyone clear on this? Yes? All right, great. I think this is it for today, but I will be doing a weekly review next week for this one. So just in case, we will try to do more challenging questions and then I'll see how you are doing. But if you need any help, just let me know. Yeah, it's the main difference is the blood pressure and the potassium levels, Amir. Both have androgen access. You'll see the ambiguous genitalia thing that I had told you earlier, right? All right, so Dr. Shah must be waiting for you on the other link. He's not joining on this link because I have